I can't hear it.
Madam, which is audible? Audible in the body?
Okay, Dr. Meena, can you hear me?
It is visible, ma'am. Screen is visible. Your screen.
कैसे आ रहा है? Once the treatment was reduced to thoracic compartment, only 10 kg per pound. If the thoracic compartment is outside the environment, they send the patient already. Actually, in America is through that. So most of the we go to primary department. Europe is more conservative. We know, but Europe. But in America, definitely. Legitimation of the people. That's the new if I'm not done, I also want to start actually by telling I have to develop my yeah.
But it is done or not done.
The diagnostic productivity is one thing, but we are able to remove the peeling out. If you are able to slightly reduce that compartment, then we can go to the abdominal compartments. After we try to reduce the abdominal compartment, we sustain. Some set of tubes in the abdomen and some set of tubes in the fluor. So कभी ऐसा भी होता है कि डायरेक्टर में ब्रेन हो जाता है तो क्या करते हैं कि जब ब्रेन हो जाता है उसको रिपेयर करने से पहले
कौन सा मसाला माइक तो बंद करते हैं
ट्रांसमाइग्रेटिंग कैल्शियम
यहाँ का आवाज वहाँ जा रहा है यहाँ से वो थोड़ा सा म्यूट करिए तो आवाज नहीं जाए अच्छा वो
way that PPI is too high for any standard CRS or pipette. There is validation for ascites management. Sometimes pipette is being used as a bridge surgery. You do repeated pipette and patient becomes a candidate for HIPEC in some time. And definitely, when there is multiple chains of chemotherapy has resulted in failure. So what is basic principle governing this? There is a specialized pen, I will be showing you in some time, a capno pen. This was a prototype, it's a type of nebulizer. There are other companies also manufacturing it. So it's possible that you can
वो मेरा काम थोड़ी है सर इसका वीडियो वाले
this is what nebulization actually means. This is how a flower with no strong appearance of the drug that comes out once it's in use. The nozzle
बड़ा
is very fine, it's 3.2 millimeters, and the spray cone angle is about 70 degrees. The blue droplets and
वहां से होगा ना यही से कुछ कर लेंगे यार अरे वहां से हम अभी हम बोले यहाँ से कैमरा चेंज होगा अभी आप यहाँ पे नहीं है हाँ हम वहाँ फोन करके वहां से करवाए यार दोनों जगह से होगा तो वहां से करवाए यहाँ से कर दिया जब हम बोला जाएगा तब लगे फोन करेंगे है ना आपको वहीं से करना है दोनों में चल रहे हैं ना ठीक है कर लेंगे
on the size of the patient. So the advantage here is that you are giving high local concentration with very low systemic toxicity. And the other part which is very good is that it can be repeated at least 3 times after 6-week interval. So how we do it, I will show you in the dry demo also, but just a brief. We need to stage the PCI assessment, preferably with an MRI, and do repeated MRIs to assess the disease progression or regression. And in the initial part, we do a diagnostic laparoscopy and find out the PCI surgically. However, the port placement should be minimal. We use generally 2 are advisable, 5 mm for camera and the closed outlet suction, and 12 mm for the capno pen. And it is advised that every time you go in, you should do at least a 3 or 4 quadrant peritoneal biopsies. These are very small 3 mm, 5 mm biopsies. No additional lysis is permitted because pipette can cause, if there is a serosal tear in the intestines while doing additional lysis, there might result in operation. So all that need not be done. And then we put in this nebulizer or the capno pen, which should be free floating inside the abdominal cavity with absolutely no bowel contact. And once it is all set, all stuff moves out of the OR and aerosol chemo delivery is done either with a remote control injector, or the wire should be such that it can come out of the theater. And as for anesthesia, as Dr. Ray was discussing during surgery, and that sometimes or most of the time only not inhalation but IV anesthesia is used so that everything can be controlled outside the OR. So essentially it's a closed exposure, and once the procedure is over, one person enters into the OT and stops the CO2 and opens the exhaust valve. So it's a closed suction drain. There is no contamination in the OT atmosphere. And once that is done, the rest of the team enters. Other important point is that all these are disposed of as a chemo disposal system, completely separate of all the things without contamination. The nebulizer generally takes 7 minutes to deliver the drug, depending upon what kind of drug we are using, right? So if there are 2 drugs, they are given one after the other, or and thereafter a total time of about 30 minutes is left for the drugs to act in the abdomen. So it's quite a short procedure, so to say. So what are the drug protocols that we use in appendix and colorectal? It's mainly oxaliplatin and mitomycin. If the patient is allergic to oxaliplatin, I'm not sure if mitomycin is available in India. Dr. Neha will tell us. As far as ovarian, gastric, hepatobiliary, mesothelioma, it's a double drug, which is cisplatin and doxorubicin. A word of caution is that these are not yet FDA approved. They are off-label use that we are doing, because pipette is still under phase 2 trials in most of the centers. And I think in UP, we are the first center to demonstrate it. It hasn't been used anywhere in UP to the best of our knowledge. So what actually are the outcomes? We are hoping to achieve a peritoneal regression. There is a separate peritoneal regression grading that has been advised, and I'll just go through it in a while. There is good control of ascites. It has a downstaging potential. The best thing about it is it's a short procedure with minimal morbidity. right? And it can be sandwiched with systemic chemotherapy in the same sitting. So we don't have to wait for any week or 2 weeks or 3 weeks before we can start systemic chemotherapy immediately after PIPEC. Similarly, bevacizumab is also not a contraindication. Unlike in HIPEC, we have to wait for about 4 to 6 weeks before we start HIPEC in a patient who has been treated with BEV. So as I was telling you, this is the peritoneal regression grading score, and it was again proposed by Solas et al. From Germany. And it scores from 1 to 4. As you can see, it's a pathological grading where 1 is complete response and then 4 is almost no response. And it depends how many tumor cells are left, what is the kind of fibrosis that remains, right? So this is how you, after every time you do a pipette, then you see how much the tumor has responded. So safety remains paramount, although this procedure looks very safe overall, but you have to be very careful while using it. It's a closed system. There should not be any contamination of the OT. The OT should preferably have a laminar airflow, HEPA filtration, or a closed, if you don't have that, you have to have a smoke evacuator system so that the exposure to the staff is negligible. Although there have been many studies that even otherwise exposure into the OT atmosphere is minimal, negligible. But over a period of time, it can cause harm, which nobody knows as of now. So it's best not to have any exposure to the best of our ability. So with this, where pipette fits in today is perhaps this. In resectable disease with low to moderate PCI, like CRS and HIPEC, we are doing as a curative procedure. For borderline cases which are potentially downstage, maybe there is a role of HIPEC in the neoadjuvant setting along with systemic chemotherapy. That's a biotherapy. And if the patient gets sufficiently downstage, they can proceed to CRS with HIPEC. Unresectable disease, of course, there is a definite role in palliative studies. So with this, in some time, I will show you from the theater how the capnopen actually works. Thank you so much for your kind attention. If there are any questions, we can have a discussion. Oh, Dr. Ray is here. Dr. Ray wants to tell.
think that Dr. Monica mentioned about this for the piping that oxalopath for colorectal and gastric cancer, that is mitomycin and oxalopath. Oxalopath is the commonly used drug for the piping. Mitomycin, some literature shows they started with the mitomycin, but presently they started with the colorectal and gastric cancer. Only docetaxel, that is 20 milligram, oxalopath is 90, and that is doxorubicin is 4 milligram. That is the peak dose for the piping at presently we use, and most of the people they are using for the piping. So those is very important. Usually we remember that 10% of the systemic dose we use in the piping because that goes under the pressure. So chance of bowel perforation is much more higher if you use the more. So 10% of the total system.
Hello.
And rest of the thing, one important thing to understand that is the primary procedure and not like a curative. Even some literature shows those who are using routinely the pipette, they're feeling the 5 to 14% only there is a chance of complete response, or you can reduce the PCI and you can go for the CRS and HIPEC also. But one important thing being, I think that Indian scenario, if you see the par setting, in the government setting also the capnopen is costly and 2 lakh rupees par setting you have to use for the palliative procedure. So it's kind of like, I feel like morally, my moral doesn't support for that.
Inflate once we inject some air. So can you see? Can you hold the mic for me? So can you see this?
Yeah,
This is a balloon.
yes, it is visible like a Foley's catheter.
Yes, exactly. So, and then there is another one here. So what happens is, please follow this here. So now, if you can see, this balloon has been deflated. Okay. Now we go inside the abdominal cavity like that, and then inflate it. Maybe. Okay. Can you go down? Yeah. So the purpose is that we will pull it out, and this one also sits. So the coat is actually sandwiched between like that. So it is sandwiched between the two balloons. So there is absolutely no chance of proper dislocation and any aerosol leak. So that is why balloon procars are very important in a pipette procedure. So like can have liquids. So normally we use only two ports as I said, and this one supposedly is our 5 mm port through which, as you can see, this is a normal laparoscope, okay, telescope which goes into the abdomen, just like that. You can show. Can you show the screen? Screen, Mikhail? Okay. So that's how we do a normal laparoscope. So this is fixed on a book Walter retractor, which they did not give. So now if I take it out, the other thing that you can see is this is a closed suction drainage. Please show it here. You don't have to show me. So this is the camera port. Okay, the camera port is connected with a suction outlet. So this is a closed suction waste disposal. So there should not be any absolutely no contamination of the OR atmosphere. Do you agree? Yes. And the other thing is then this is the other port. This port has to be a 12 mm port because this capno pen, this is actually a nebulizer. Can you focus on the pen, please?
Hello.
So this is a capno pen. This has a shaft diameter of about 11 to 12 mm, which will not go through a 5 mm port. Please, Gautam, please move aside. So this will go only through this 12 mm port. So generally, where to place these ports is also a big question because generally in advanced cancers, this abdomen has serious adhesions. So generally, it is advisable to keep the this capnopen port in the lower quadrant or whichever after you establish a pneumoperitoneum and put in a camera port, you have to tailor it accordingly. So generally, it is advisable to put it in the lower quadrant. And as you can see, where to put the scope. Can you just show inside this? So this port should be freely floating in the abdomen. It should not be touching any bowel. And if you can't take it out, can you please hold it? It has to be fed out. Can you just again please show focus here? Please don't remove your focus. So it should not be like jutting out of your port. It should not be inside the port. It should only be sufficiently outside so that the aerosol comes out. There should not be any clogging here and there or no touching of bowel in any circumstances. Otherwise, you will have lots of problems in the post-operative period. Okay? Yeah. Can you handle? So as for this capnopen, as you can see, this is connected through a lure lock mechanism into this injector system. Now please focus on the injector system. In most of our CT scan rooms, it's preferable if you are doing a pipette procedure, then you should buy your own. Costs about 4.5 to 5 lakhs. And as please come, you have please focus on this. So this is monitored by. Can you focus on this? this is a monitor. So if you're not able to see it. So it will show you the flow rate. It will also show you the volume. So the volume or the drug is filled in here. It is pre-filled as you can see. And everything is all set and then everybody moves out of the theater. These procedures are not done while being inside the theater. So they have a long connector systems. So generally this monitor is kept outside the theater. Right? So now, please can you start? So you have to focus it so that we are able to understand what's happening. You have to come here. So as you can see the syringe, can you just focus on the syringe first? This syringe is already filled. How much is it? 50 ml of the drug is there. It's all in this situation, it's normal saline only. And here, can you just focus here? Focus it more. Can you see it's 50? The volume in here is 50 and we have set a flow rate of 0.4. It can go up to 0.8 also. And then there is pressure also. It's 280 psi pounds per square inch. Okay. And so that is how everything is set. Now, once this is set, then here what we have, again, please focus. This is a wired connector. Normally, we also have a remote injector. So we can actually be outside the theater and then start the injection process. So now, I'm sorry, what's your name? Okay, Mr. Nathan is going to demonstrate how it really works. He is going to push the button and you can see.
And to start, we'll just push this one. Now injector.
So now the system is charging up and in a while you will see, can you see this? I'm not sure.
Yeah, we are able to see the mist is coming out from there.
Yeah. So it's called a Swiss snowstorm. So this is how the particle size, as I told you, is 25 micrometer. It's very small. So it goes inside the abdomen. Now they have come up with a modified tip also. It's called the capno tip, which is there is an omega some kind of a thing there, and the spray angle becomes 150 degrees. And then there is something called electrostatic pipette also, in which they use a charger so that distribution inside the abdomen is very homogeneous. So it's completely soft. But we have to be very sure that there is no OR contamination here. Can we stop this? So what happens is, add as you got. Can you just no, don't start it inside. So as you can see, once you have prepped up your patient, the camera port is here. Your telescope is inside the abdomen, which is held in a book Walter retractor system. If you have robotic ports, that's fine. If you don't have, you can just use the retractor system that you have. It is very important that these are not moving during the whole procedure. They have to be very static. And then you make sure that all the lure lock systems are working fine. This is the CO2 insufflation. Sorry, I beg your pardon. This is the
Suction.
exhaust, the outlet, and this is the CO2 insufflation. And once everything is primed up like this, the anesthetist, all the OT team moves out. And I repeat, all of them we have to move out of the theater, and then we start the charging system. Now this spray will continue for about 7 minutes. Thereafter, we have to wait for another 30 minutes. So the whole procedure is not more than 45 minutes overall. So once 45 minutes are over, one of the OT staff will enter with full getup, complete protection masks and everything. Come inside the theater, stop the CO2 insufflation, and open this exhaust valve. So everything gets slowly in a closed circuit, it gets evacuated, and then the rest of the team enters the theater and does the disposal and removal of the traumas. Dr. Ray wants to say something.
Regarding the port placement, that is very important in case of pipette, because normally the first port that is to around umbilical concentrator right side to the umbilical falciparum is attached. keep the right side, that is for the only the telescope. And another port, normally, usually what happens, you see this even the metastatic disease, particularly Rama, the right, the palmar face, that is the left subcostal area, 2 finger bit below. That area is usually 90 to 95% cases you can put the port there, second port. So that is the thing. Otherwise, suppose always you have to palpate this thing, whether you feel that there is no disease is there, then you have to go. So usually the people are putting, even I put in this farmer state, and that is usually 95% is we are able to do. And regarding the drug also, the Dr. Molika is telling like you do the auxiliary pattern, you have to add only 5% dextrose, so that you cannot add with this normal saline. Then you docetaxel and suppose doxorubicin, that you can together we use with this normal saline, but dextrose to be used for this auxiliary pattern. So that is one important thing, and most important thing is that not all palliative procedure you should go for the pipette. There is absolute condition if the patient having intestinal obstruction, because there is chance of perforation is almost 100%. So that is very absolute condition. If the patient having the history of obstruction, you should not go for the pipette. And the another is contraindication is the decompensatory ascites. So when the ascite level is more than 5 liters, you have to take care about that thing. So that is most thing, but adhesion itself does not contain for the pipette. So if the patient is having the adhesion also, you can go for the pipette, but not in the huge ascite is more than 6 liters and history of intestinal obstructions. So that is you have to take care. So that is just I have it, other everything she explained properly.
That's a very important point. Why dextrose is used for oxaliplatin and normal saline for other drugs, because the drug has to be stable enough in those circumstances. If you mix oxaliplatin with normal saline, there would be problems. And this is the same concept which applies in HIPEC also. So you have to be very sure where you are diluting your drug. Any questions from your end, please? We are most welcome.
Sir, it is shown that in the aerosol, it is the tumor cell is present or not?
Even what is you told the question?
Dr. Meena, can you repeat your question, please?
So it is just all the staff will be out from the OT
Yes.
because the aerosol which is generated it might be having a tumor cells. So it is.
So that is true. There is a cytotoxicity, because there is so many literature is there. The cytotoxic diet causes so many problems in the body. But with the women, that is called infertility is there, and the toxicity, the abortion history is there, and all the drug toxicity, even in the allergy also. Some people are allergic, even some kind of reaction is also their skin, mucous membrane. So you have to avoid that thing. That's why that the balloon procar is to be used. We have to protect that. So many toxic effects are there in the body, human body. And because that is under pressure and aerosol is there, that is the most dangerous thing. If you stay with this thing anyway, directly, indirectly, you will be exposed in that. So you have to avoid that.
Yes, and Dr. Meena, there have been several studies which have been published that contamination, if you do a setup like this and are careful, contamination is minimal. But if you are doing repeated pipettes in lots of patients, there is a possibility of the team getting infected over a period of time, which we definitely want to avoid. As far as aerosolization of tumor particles is concerned, it's not that much of a significance as much as it is for the chemotherapy. Because we have our own immunity, which will not, by touching cancer, it doesn't spread like that. So we have our own immunity, which will counter that. But chemotherapy definitely over a period of time can have negative effects. We do not have a robust data to back it, but overall, whatever data we have, it says that it's sufficiently safe.
Thank you.
Anything else for Dr. Ray? Yes.
Ma'am, a simple question. When we all leave the operation theater, how are we supposed to keep the capnopan at a specific distance in the trocar, as you said earlier? Does it have a system, a lock kind of system, that it stays exactly at the tip of the trocar?
That is you can see this thing. When you see through the telescope, you get camera, you can see this thing, the total aerosolization is there. And normally we put the omnitract, any detector and fix it. So that under the pressure, any movement is there, it could be displaced. So that's why we always fix with this. We put the like any omnitract or Thomson, any detector and fix it. So that would be in the proper position. So that usually we do this.
And then see, if you can see, it fits very snugly. So the chances of it sliding down are minimal if you have a proper trocar, new trocar that to be used. And then the thing is that it is a completely disposable setup. You cannot reuse and reuse this, any of it.
Yes.
Think of it as you are doing a transplant procedure, you remove everything away. So, so
Thank you.
it generally doesn't sit down, and as I told you, the tip where you put the tip of the same capno pen is very important. It should not be jutting into the abdomen, neither it should be within the shaft of the port. It should be just outside, sufficient to provide a good aerosol without injuring any bowel. That is why there is a lots of adhesions in the abdomen. This pipette procedure cannot be done, and it should never be done with an additional lysis. Like if you think that I will do additional lysis and then immediately do pipette, it's a big no, 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 because there will be perforations and it's just not done.
Okay.
Yes, definitely. Otherwise, how will you know how you will not know whether it is responding to your treatment or not.
Any
Yes.
cooperative concerns in such cases, like when to start orals or?
Oh, no, nothing is there. Like, this is the kind of drug delivery system, that one has to understand. Nothing is there, no problem is there. You can just start immediately with oral seeds and everything, and we discharge the patient in the same day, until some problem is there. So that is one kind of drug delivery system, like a chemotherapy. We give the chemotherapy and there is daycare system. We discharge the patient after chemo, the same we can discharge the patient. That is the good part of the pipeline.
Yes, and Tarun, we can give systemic chemotherapy the same day. Suppose you admitted the patient, like in Western centers, we do not admit 2-3 days before. You admit the patient in the morning, do pipette, take the patient back to the daycare, give systemic chemotherapy, and maybe discharge them tomorrow they are stable. So it's that safe.
I think it should be given 3 weekly, like.
So there is a question by our in-house doctor.
The high pack, if the patient becomes operable, then can we go for CRS plus high pack also in those patients?
So that is his question is there after pipette also whether we can go for the CRS and hypec, because the literature says 5 to 14% patient having the good response to the pipette. And then the PCI is low, and if the PCI is low, if you just try to do, you can go CRS and hypec. I mean, there is one of the good part of the pipette.
So that is a new adjuvant, as Dr. Ray has said. It's used in new adjuvant, but you do not expect dramatic response in most patients. But if the ECOG status is good, PCI is responding, then definitely he or she can become a candidate in. So you can repeat this pipette not indefinitely, but at least 3 times. And the interval is about 6 weeks. You need to score PCI by that scoring system, pathological as well as repeated MRIs. So don't overdo the case if they are not going on a right trajectory. Be very selective. So it's
Ma'am, sir, ma'am, to check the PRGS, that pathological response, we have to do biopsy, laparoscopic diagnostic lab and biopsy and check the response.
Because the same put you can take the biopsy.